going to talk today about the beginning of robotic interventions. And I love robots. And I think robots can do a lot in improving the way we treat many different kinds of disease states. But I'm going to talk a little bit about also how we start to bring these kinds of technologies into medicine and how we look around for technologies that we think have the ability to help us improve patient outcomes. So the robotics in the Da Vinci surgical robot have their history in the telemanipulation systems that were developed in the 1950s by Gertz, who was looking for a way to manipulate things in a dangerous environment from a safe environment. And he had these telemanipulators that were set up in a master-slave sort of role. And until about the mid-1980s, this was mostly the way this sort of telemanipulation was done. But in the 1980s, there was an enormous expansion of the different kinds of robots that we saw out there, going up into space, down into the depths of the ocean. And it wasn't because of new changes in thinking about what robots could do that drove it. Those changes in thinking were able to be realized because of changes that happened in microprocessors and small sensors. And so it was the electronics changes that suddenly unleashed this enormous proliferation of creativity in the development of robotics. Not people thinking, oh, I want robots, and then they went and developed the electronics in order to do it. And so that had a very unpredictable effect in an adjacent regime from the electronics. So around the same time, however, this is still what surgery looked like. Big open incisions, where you needed to be able to make a large enough incision that your eyes could see what you wanted to manipulate, and the hand could get inside, and so that you could bring tools inside. It was those same new breakthroughs in electronics that led to the next change in surgery. Because you could make cameras smaller, because you could make the electronics so that you could hold a lightweight camera, you were able to move to being able to do surgery through very, very small incisions in laparoscopy with a camera that's looking inside, inflating the belly with gas. Now, laparoscopy in earlier forms had been around for almost 80 years, but it hadn't really caught on. People hadn't really started to be able to do lots of different kinds of surgeries with it until the electronics got small enough that it was able to make that leap. And what that did is it allowed us to do the same kinds of surgeries inside the body that we were doing through large open incisions, through very small incisions. And this was a big victory for the patient, but there was a limited number of procedures that you could apply this to, because as they got very, very complicated, it got more and more difficult to do the laparoscopy. So we were going from here to here. And so now you can see that you've got multiple people in the OR. The ergonomics are somewhat challenging, and the surgeon is working through long sticks, and then when they put their hand left, the tip of the instrument goes right, and when they put their hand right, the tip of the instrument goes left. So everything's reversed inside. And as for relatively simple surgeries, that's fairly easy to do, but when things get very complicated, you end up with a lot of people working on it at the same time. And so that was what the Da Vinci robot, bringing the robotics and the minimally invasive surgery together, was intended to address. It took all the capabilities of a wrist and it put them on the end of that long stick. And now through telemanipulation, every motion that the surgeon's hand is making the same motion on that instrument inside. It's like a tiny pair of surrogate hands. So you can repair the valves of the heart from the inside of the heart, or you can work in the abdomen through incisions that are only about 8 millimeters in diameter. And all of this has an enormous amount of technology that is now sitting between the patient's tissue and the surgeon's hands, and the patient's tissue and the surgeon's eyes. And so we've put this big telemanipulation robot in between. But the Da Vinci, although it's the best known of the surgical robots that are out there, is by no means the only, and it was certainly not the first. What you see here is a TURP robot, transurethral prostate resection, which was sort of like a milling machine. It was a fixturing and cutting, and you imaged, and then it went transurethrally and cored out the prostate. The other one is the Minerva in the middle. That was a cranial surgery where the halo attaches to the patient's head, and you can drive probes in. And the one on the right is RoboDoc, which was a unfortunately named robot for coring out with high precision a hip implant. In addition, there's a lot of surgical aids, sort of surgeon extenders, such as scope holders, rounding robots so that you can go, telepresence robots, so you can wander around the hospital and round on your patients in your pajamas from home, and other things that will hold or provide navigation in the operative field. We're also seeing a whole host of robotics that are using haptic interfaces or guiding interfaces to allow the surgeon to do a particular motion on the patient, but it's constrained by the robot. And so what you see on the left is the Mako surgical robot, and that is for very, very precisely cutting out the implant paths for putting a knee implant in. Or the Mazor on the bottom right, which is a guide that allows you to put pedicle screws in very, very precisely. Now, the surgeon is still placing the pedicle screw, but they're constrained in the orientation and the depth that they're going to put them in. We also see robots that are starting to show up in the bore of the MRI so that you can do an intervention while you're while you're imaging the patient. And so this one, the one on the right is a prostate biopsy, and the one on the left is an intracranial robot for being able to image the brain while you're doing surgery on it. Robots are also being used not just in the surgical field, but in radiology. This is the CyberKnife, which, following fiducials placed around a tumor, can track the breathing and track the patient's motion so they can put extremely high doses of radiation in a very precise point without it getting smeared around by the patient's motion. And so that tracking of the robot allows you to use that tool and radiation as a tool in a much more precise way. Robotics also allows you to start changing the form factor of the type of surgery that you might do. These are catheter and flexible-based robots. Up on the left, a catheter that you can feed in through the femoral artery, bring it up into the heart, and be able to ablate for atrial fibrillation. There are robots that can do non-looping colonoscopies. For those of you that have been well-behaved and gotten your colonoscopies, you would like to think that there would be better ways to do that. And driving it in so that it isn't looping and isn't causing pain as it's going around the corners is something that can be done with robotics. There's also robots that can go in below the xiphoid or down the throat and be able to do operations in these curved, confined sorts of spaces that you can't reach with a straight stick. Then, of course, there's my favorite robot, the Da Vinci robot, with a host of tools that does a lot of abdominal, thoracic, and also transoral surgery. And so you'd think that we're at the pinnacle of this kind of robotic technology, and this is all really cool, and this is the future of intervention. But from where I'm standing, we're really not that much further away or further down the path than we were when we had these. These are surgical knives unearthed in Pompeii, and if you cleaned most of the rust off of them, they wouldn't look that out of place on a modern laparotomy tray. But the reason why I'm saying with all this high-tech robotics, we're not really that much farther beyond these, is because by definition, what we're doing on the inside of the patient is exactly the same as what we were doing when we opened with knives and cut large parts out. So we haven't really changed what we're doing in surgery very much. Now, for the patient, a big open incision like this is a life-changing event or can lead to lots of problems downstream. And so I don't want to trivialize that going in minimally invasively is a significant improvement. But to illustrate this point, this is a chart of the stages of lung cancer. And in a very early stage, when your tumor is less than 2 centimeters, if we find your cancer at that stage, at 5 years, you have a 77% chance of making it to 5 years. A little bit larger, up in the 3 to 5 centimeter range, but still not spreading very far, you've got about a 58% chance of making it to 5 years. Stage 3B, you've got about a 50-50 chance of making it. 35%, if we get to stage 3A, we're starting to involve lymph nodes, we're starting to get things crossing over, and we're starting to get sort of more local spread and distance into the lymphatics, and you've got distant metastases, and you've only got an 11% chance of making it to 5 years after diagnosis. And today, the average 5-year survival with a diagnosis of lung cancer is 15%, which means we are absolutely not finding it in stage 1A and stage 2. We are finding it too late. And so you take someone who's got a diagnosis of lung cancer today, and you bring them into the operating room, and I can use the coolest, highest tech robot on them, and I cannot move the needle. I cannot make them live past 5 years. And so what we're really got to be thinking about is the robot and these interventions are tools if we can be smarter about how we're using them. And so when I think about really disruptive technologies, when I think about breakthroughs in this area, I think about things that look like this. And some people have seen this in talks that I've given before, but I love the dog's nose. And I love the dog's nose because dogs can smell cancer on your breath. They can be trained to detect cancer. And if dogs can be trained, we're not really quite sure what all of the elements are in the breath that they're being responsive to, but at some point we must be able to detect it this way. And if we can move that needle earlier, then we can get to the cancer when it's at that 60% 5-year survival, or even better, at a 90% 5-year survival. Or maybe we can start thinking in terms of surgeons as harvesters of tissue. Tissue is the issue. If I go in and I take out a piece of that tumor, and I go over to my colleagues in immunotherapy, and I say, this is the patient's tumor, they can take the T cells from that patient, sensitize it to their own tumor, and then use their body to mop up all of the rest. I'm just debulking and providing the sample. And then you can help the patient finish it off the rest of the way. Or maybe we ought to be looking at other adjunct technologies like viruses. There are some adenoviruses that attack breast cancer. And we need to be thinking in terms of if we debulk and then add, or maybe we just infect ourselves with adenoviruses every year, get an extra cold, and wipe out all the cancer in our body as we're going along. Think about it as maintenance rather than ever needing surgery. Or there are things like nanovirucides that are out there, which people are looking at getting rid of the common cold, but we've seen virally mediated steps in almost every cancer that we have studied. And if you were to interrupt the virally mediated steps of all these cancers, maybe we're taking the therapy even further back, not in the treatment stage, but in the prevention stage. And so where does robotics fit into all of this? Robotics allows us to really move outside of the scale of how we interact with our patients. In the past, this has been the surgical instrument, and the hole that you cut is big enough to put this inside. And the therapies that we do, the interventions that we do, are on the scale of things that I can do with my hand. But once we change the relationship between what my hand does and the manipulation that happens on the other end, we unlock an enormous amount of ability in scale. So if I can take the comfortable motion of a surgeon's hand and I can make it microscopic or even nanoscopic, I can do things like drill a hole in a single cell with a femtosecond laser. And that means if I can say, I can tell in real time, this cell is good, this cell is bad, and this cell is good, I can zap the bad cell out from in between the two good ones and leave them behind. And so now I start to think about robotics in a realm that allows me to really think about, could I unwind cancers from around the outside of the structures that I want to leave behind and really leave the patient fully intact? The ultimate minimally invasive surgery, I don't take anything that the patient wants and I leave everything behind. So what's very necessary about this is being able to look at the tissues in a different way as well. I talked about robotics putting a lot of technology between the surgeon's hand and the patient's tissue, and the surgeon's eye and the patient's tissue. Once I put a camera in between, I'm no longer limited either at the scale of what I see or in the wavelengths of what I see. And so what you're seeing up here is a video from Roger Tsen's lab of this is a tumor that is marked with a fluorescent dye, and it is being dissected off from a leg muscle, and underneath you can see nerves. But you can also make the nerves light up with a fluorescent dye. And now we start to be able to look at and tag the various substructures so that I can say this is good, this is bad, this is good. I want to leave that, I want to take that out. And I can have unambiguous manipulation at these low levels, being able to figure out what I want to leave to keep that patient intact and what I want to make sure I take out so that I have 100% cure of lung cancer. So on the Da Vinci right now, we do have fluorescence imaging, and what you see here is a near-infrared fluorescing lymph node being dissected out of a wall. And this is a lymph node, so that's the first drainage point from a tumor where it was injected. And you wouldn't be able to do this in an open surgery because there's too much ambient light in the near-infrared. And in addition, because we can control the lighting inside the belly, we're lighting with white light interleaved with lighting with the fluorescence. And then we can display them one on top of the other so that we can give the guidance to the surgeon of where it is that they need to go to be able to take out that lymph node. And this is the first step in us being able to tag lots of different things within the body and be able to then do surgery a little bit more like numbers. And as we start to change what we're doing in scale, it really helps us think about being able to use surgery curatively and also being able to use surgery in conjunction with a lot of these other therapies like immunotherapeutics. But that is helping us unlock the mysteries of this is people being able to figure out the pathways, the different sorts of moving us down the path to being able to intervene earlier and earlier, and understanding the mechanisms of these diseases. So, anyone recognize this? It's early for a pop quiz, but... Transistor! Oh, I love a geek crowd. It's first transistor out of Bell Labs, 1947. And the folks that made this had no idea what this was going to turn into. It's impossible to be able to predict all of the various different ways in which this could affect the world. This is one of the themes that I understand was over and over again in terms of thinking about exponential changes wrought on by technology. So if we look back, 1947, my parents were around 10 years old at that time, and this is what a radio, up on the upper left, a mobile phone, they were actually radio-based mobile phones in the Los Angeles area run by AT&T, so you could actually have a mobile phone in 1947, and the state-of-the-art code-cracking computer up on the right. So when I was around 10 years old, this is what a music player looked like. This was the beginning of the Sony Walkman, where people really changed the way that they were interacting with music and bringing music with them. I'm cheating on the cell phone. They weren't actually cell phones. This is what the prototype looked like in 1979. It was another couple of years on that. But this is what computing was also looking like. So we see the rise of the supercomputers, but also computers coming out onto people's desks. And so my daughter is 10 years old, and this is a music player. Sometimes it's a phone, and it's also a reasonably good computer. Is it a revolutionary technology? Is it a disruptive technology? It's not a particularly awesome music player. It's certainly not a very, very good phone, and it's only a sort of a middling computer. So it's not really a breakthrough in any of those one particular areas, but what makes it a disruptive technology is this. I can put it in my pocket and I carry it around with me. And it has changed the way we interact with information. It has changed the way we interact with one another. It has changed our expectations on being able to, if you don't know something, being able to get access to that right away. It has been a profoundly disruptive technology to all of these areas that are adjacent to it. But it hasn't been a disruptive phone or music player or computer. And so when I am thinking about how are we really going to push medicine forward, how are we really going to push surgery forward, I am looking into areas adjacent to me. I am not looking for the folks that are doing work in surgical research or even doing work in robotic research. I am looking at things like those nanovirusides or the immunotherapeutics and thinking, how am I going to fundamentally change how intervention benefits patients? How do I narrow that gap between what we want to be able to do for patients and what we can do for patients? And how do we integrate those all together so that we can get that best possible benefit? And so this is the way I look at the future. This is my crazy looking at the future hat. But I would, and I wear it at Halloween as well and scare the kids when I'm handing out candy. But it is, I think, an excellent way of thinking about trying to be prepared for these technologies that are coming down the pipe and trying to figure out how you're going to integrate them and how we're going to fundamentally change what we do with intervention.
Thank you, Catherine.
All right, thank you.